Hello, I am audible to you?
Yes, sir. Now you're audible. You can introduce Dr. Edward.
Now I welcome our second speaker, Dr. Edward Jude. He is consultant physician and professor at Professor He is a professor in medicine honorary professor at Manchester University. He has done his undergrad at Manchester University and then completing his training in diabetes and endocrinology. He took up his certain post in he has 140 chapters. He secured grant from diabetes, HT, and so on. His studies including trials, and function he passed a term of diabetes and on the for he is also chief for the product
शेयरिंग नहीं हो पा रहा है मेरा इसलिए
अभी हो गया आपका आवाज है
Yes, Dr. Edward, your screen is visible. You can put it in slideshow and you can begin with your presentation. Dr. Edward, need to unmute.
Can you see my slides?
Yes.
Yeah, yes, sir.
Okay. Thank you very much. And thank you, Rajneesh, for that kind introduction. Thank you to Dr. Sabu and the organizers for the invitation to speak on the COVID crisis and the diabetic foot. And it's a pleasure to be on the same platform with Vijay, who we've been friends for many years. So Vijay, good to see you. So I'll be covering East versus West on the COVID crisis and what's happening currently in the world, mainly to do with diabetes and the diabetic foot. These are my disclosures. So COVID-19 or coronavirus disease 2019 was first described in Wuhan in China in December 2019. It was called the Severe Acute Respiratory Distress Syndrome Coronavirus 2 or SARS-CoV-2 in February 2020 because it is genetically related to the coronavirus responsible for the SARS outbreak in 2003. It was declared a public health emergency by WHO in January 2020 when more than 100,000 people were infected in over 100 countries. It is the biggest pandemic to hit mankind in over 100 years. The last pandemic was as you all know, the influenza pandemic of 1918, 1919, where up to 50 million deaths occurred globally. What we know about the pandemic in 1919 was that when the virus mutated the third and the fourth time, that's when the number of deaths increased phenomenally. And that's why the concern at the moment that the current virus has mutated and there's a worry that we may face similar deaths globally. So what is the coronavirus 2? It is a beta coronavirus. It's a single-stranded RNA virus with a genetic sequence similar to coronavirus 1. It shares 80% of its genes, similar gene sequence with the coronavirus 1 and a 96% similarity with the bat coronavirus. It has a viral envelope which is coated by two spike glycoproteins S1 and S2. The S1 is the protein that binds to the host cell receptor, which is the ACE2 receptor, and promotes entry into the cell. And the S2 spike protein promotes fusion of the virus and cellular membranes, fusing the two cells. Because ACE2 is represented so well and extensively in the lungs, it is the lung that has the peak viral load, with people being infectious up to a week after developing the infection, being most infectious 5 days after developing symptoms. Diagnosis is made using RT-PCR of swabs of the upper respiratory tract, and swabs are usually positive up to 9 days, but some can be positive up to 14 days. So this slide, this cartoon down here shows the S protein that is attaching to the ACE gene receptor, and this then enters into the cell. So looking at the global severity of the of COVID-19, this is data up to this week actually, so 51st week of 2020, and you can see the numbers increasing exponentially over the last 50 odd weeks. There have been 78 million cases globally and 1.7 million deaths reported globally. And again, this graph here at the bottom is showing the deaths that have occurred up to this week. What about COVID-19 in the UK and India? On the left, here is data from the UK. There have been 2.2 million cases in the UK to date. This is data up to day before yesterday, the 25th of December. There have been 70,000 deaths, and on Christmas Day, unfortunately, there were 32,000 cases reported in the UK, with 570 deaths occurring on Christmas Day. What about in India? There have been 10 million cases reported in the last 11 to 12 months, and 140,000 deaths reported in India. You can see the numbers gradually increasing in the UK, and this is the worry that the virus has now mutated and the numbers might start to increase, especially with the setting in of winter and the freezing cold. There's a risk that numbers might increase exponentially in the UK. So what are the risk factors for somebody developing COVID-19, severe disease, admission to ICU, and mortality? Because of this conference, I would like to stress diabetes and obesity, but even other comorbidities such as hypertension, cardiovascular disease, etc., can increase the risk of people developing severe disease. People usually present with high fever. They have raised CRP, IL-6, and D dimers. And what's important of these four features is that all these four features also will be seen in patients with diabetic foot. So what we need to understand is a patient presenting who's got diabetes and has these symptoms, one must also think not only of COVID, but have they got underlying diabetic foot disease, because there is a similarity in the presentation of the two conditions. What about COVID-19 and ethnicity? The reason for this is that in the UK, we were seeing a lot of ethnic minority people developing COVID-19, but also among healthcare professionals. And unfortunately, there have been quite a few deaths among healthcare professionals and doctors in the UK. So there was an investigation into why so many of our ethnic minority people are developing COVID-19. And this editorial in the BMJ recently describes this as a possibly socioeconomic, cultural, of lifestyle factors, along with genetic predisposition that leads to some of these ethnic minorities developing COVID-19. But probably more importantly is the increased prevalence of vitamin deficiency among people with darker skins because of the inability to manufacture or synthesize vitamin D when they are exposed to sunlight. So why the interest in vitamin D? Is it all in the latitude? And because when the COVID-19 numbers were increasing dramatically in the West, they found that it was mainly in countries that were north of the 35-degree latitude or the 35 parallel. And you can see Belgium, Spain, UK, France is up there, Sweden, USA, Switzerland, all countries that are further up north compared to India. What about vitamin D and mortality? Again, you can see the mortality also was increased in countries that were above the 35th parallel, but also vitamin D deficiency showed here in red dots, showed increased mortality in patients who had low vitamin D levels. So what is the evidence? Just one slide I'm going to show you. On the left here in red is patients with low vitamin D levels, and on the right here in blue is patients with adequate vitamin D levels. You can see that those who had low vitamin D levels, that's more severe illness, raised CRP, low lymphocyte counts, hypoxia, and higher inpatient mortality. So there is some evidence that vitamin D does play a role in people developing COVID-19 symptoms. What about vitamin D and the diabetic foot? So this study we did in Bulgaria, and we looked at a population of patients with diabetic foot ulcers, type 2 diabetes with neuropathy and without complications. And we showed that patients with foot ulcers had low vitamin D levels when compared to patients without foot ulcers and neuropathy and patients without complications. So there is a definite underlying reason for why people with vitamin D deficiency get foot ulcers. I mean, you look at the prevalence of vitamin deficiency in people with foot ulcers and those without foot ulcers here on the right, you can see that most patients actually were vitamin D deficient, but vitamin D deficiency was more significant in patients with diabetic foot ulcers. What about vitamin D in patients with diabetic neuropathy? Again, studies have shown that patients with neuropathy have got low vitamin D levels, and there is it is implied that vitamin D may play a role in patients developing neuropathy and other diabetic complications. So what we did in this study, we gave patients low versus high dose vitamin D on a weekly basis, and we measured their microcirculation, and we showed that patients who were given the higher dose vitamin D at 24 weeks showed improvement in blood flow as measured by laser Doppler microcirculation. We also then looked at other risk factors. Firstly, to show you the vitamin D levels, it improved as you would expect. In patients who were given the high dose vitamin D, there was not much change in patients who were given the low dose vitamin D. But there was an improvement in HbA1c. Despite no change in diabetic treatments, we saw an improvement in patients who had high dose vitamin D. There was no change in those who had low dose vitamin D. There was also an improvement in IL-6, and we know that IL-6 is one of the main cytokines that's involved in the cytokine storm seen in COVID-19 and the ARDS that these patients present with. And we showed a significant reduction in in IL-6 in patients who were given the high dose vitamin D, and there was no change in the low dose vitamin D patients. We also showed an improvement in the anti-inflammatory cytokine, which is IL-10. And again, you can see there was an increase in high dose vitamin D patients, and there was no change in patients who had low dose vitamin D. So vitamin IL-6 is known to upregulate ACE2 receptor, and we know that the COVID-19 or the coronavirus 2 enters into the cell while the ACE2 receptor, vitamin D, reduces cytokine production, including IL-6, and therefore there may be an implication of using vitamin D in treating these patients. So what about in the diabetic foot and in COVID-19? How can we improve the outcomes? And there were some really good papers from India and also from the West, and Vijay also mentioned a study himself of some work that they've been doing in Chennai. This algorithm here shows the interaction between the patients with diabetes, COVID-19, and diabetic foot ulcers. And the main impact here again is vitamin D, but also the increased coagulopathy seen as a result of COVID-19. And we know that patients who develop COVID-19 infection, they increase risk for developing pulmonary embolism and raised D dimers. But this increased coagulopathy can lead to increased risk for peripheral artery disease. So there is a definite interaction between COVID-19, the coagulopathy, peripheral artery disease, vitamin deficiency, and ultimately this patient developing diabetic foot ulceration. So there may be some interactions between somebody who's got a COVID-19 infection and them developing diabetic foot ulcers. This is a new term that has been coined recently. It's called COVID toes. And these patients present similar to chilblains. And they present with painful burning sensation in the toes. And you can see the discoloration. They have micro ulcers or ulcers on the tip of the toes. And this may be because of the adrenal dysfunction that is enhanced in COVID situation. but it also could be the micro emboli that is seen in the microvasculature, leading to these small ulcers in the tips of the toes. So since the COVID situation has impacted globally, it has also had a massive effect on our patients presenting to the foot clinic. And many patients do present late to the foot clinic. And these are just two of the patients who have I'm presenting here. Here on the left is a patient who had an ulcer for almost 6 weeks before he decided to come to hospital, underlying X-ray showed osteomyelitis. And unfortunately, although he came to hospital with IV antibiotics, we were not able to save the foot. The patient on the right here, we managed to successfully treat the ulcer, and the patient went home with all toes and feet intact. So there is an implication, as Vijay mentioned, the increased risk for amputations for patients in the COVID situation because of the inability for patients to attend clinics, the lack of availability of clinics because of the way practice has changed over the last few months. Just briefly talk about Charcot foot and inflammation. As we all know, Charcot foot is a swelling of the foot with pain, discomfort, and deformity. These are how the patients will present. They may have mild deformity with increased temperatures and swelling, or they can have quite severe deformities if they present late to the clinic. Again, looking at the inflammatory markers, some of the studies that we have done, and we have shown increased TNF-alpha, interleukin-1 beta, IL-6, and these, as you know, as I've mentioned earlier, are similar markers that are seen in the cytokine storm. And therefore, it may be that patients who develop COVID infections may have an increased risk for developing Charcot foot, although this has not yet been proven, that there have not been many case reports to mention this. And of course, the anti-inflammatory markers, again, that we have looked at, OPG, CGRP, and eNOS, are reduced in Charcot foot, which leads to the development of this inflammatory condition. So how can we reduce complications in people with diabetes during the COVID-19 pandemic? This is a nice study done in Michigan from the Department of Internal Medicine by Schmidt and colleagues, and they call it the STRIDE study, strategies to reduce severe diabetic foot infections and complications during epidemics. They came up with algorithm where all patients are triaged when they present with a new foot ulcer, and they're divided into patients with low acuity diabetic foot, in other words, no infection, no risk for amputations, or patients with high acuity foot, so they have an infection, osteomyelitis, Charcot, etc. Patients who've got low acuity diabetic foot will have their care delivered by video visits or telephone, but patients with high acuity diabetic foot will be seen face-to-face, and then if required for emergency treatment, they will be admitted. If required, surgery will be performed and then discharged. And depending on when the high acuity becomes low acuity, they will go to video visits, telephone visits, or if the low acuity becomes high acuity, they will then be seen face-to-face. So there was an interaction between the two treatment modalities. And what did they show? They showed that they compared data from March to May 2020, so the first 3 months when the pandemic started, and they compared it to similar time span in the previous year, so 2019. So in 2019, March to May, there was only one virtual visit. This increased to 220 during the pandemic, and you can see this was a 21,000% increase in the virtual visits. Outpatient volume was around 2,300 in 2019. This dropped by 80% to 425 in March to May. So you can see that many of these visits became virtual or not at all, because you can see that the numbers don't match up between these two. So I think many patients were not being seen at all in the March to May 2020 time span. Inpatient volume also decreased by 62%. Mild amputations decreased, but if you look at the actual percentages, there was no change in mild amputation between the two time spans. So looking at diabetic foot related care, you can see that 40% of patients in 2019 were seen for diabetic foot. These numbers, so that was 938, which reduced to 416 But if you look at the number of patients who were actually seen face to face, 98% of this volume was for diabetic foot. So although the numbers decreased by 55% for patients attending face to face in the diabetic foot clinic, majority of the face to face was actually for diabetic foot patients. So that was a 1.45-fold increase in patients who were being seen for diabetic foot face to face in the 2020 cohort. This study looked at data for Manchester and Los Angeles, and again pre-lockdown here on the top row for both the cities, and the bottom row is post-lockdown. You can see in Manchester there were 373 clinic visits since lockdown. Pre-lockdown. This reduced to 208 post-lockdown. So they were still happening face-to-face, but the numbers decreased. Many patients then went on to have telecare or home visits. And also in the US from 282, clinic visits dropped down to 86, and telecare went from 0 to 113. But looks like in the US they don't do any home visits, which in the UK happens quite regularly. Looking at hospitalization, there was a 90% decrease in hospitalizations in the UK, whereas in the US it was a 2/3 decrease in hospitalization. So one wonders where these patients were actually being treated when they had severe diabetic foot infections, when we know that severity actually has increased since the COVID situation started. What about arterial thrombosis? This study, which is done again in the US, it compared to the distribution of arterial thrombosis in patients with and without COVID. So lowest hemolytic clot was seen in 100% on CT angiograms in people with COVID-19, and only in 32 patients in the control group, and this was an increase of 69%. Now all these patients were not diabetic. Only 50% of the two groups actually had diabetes. What was most significant, and we know that mainly patients with diabetes have mainly peripheral disease, and the study that we did a few years ago, which showed more below knee clots than above knee clots, which was the reverse for patients who did not have diabetes. But you can see here that patients who had COVID, they had more proximal clots when compared to patients without COVID. They then looked at the mean clot score, and again, this was higher in patients than controls, and death and amputations was also much greater in patients with COVID than those without. The odd ratios was a significant 25 with a p-value of 0.001. So patients with COVID have got increased thrombogenicity, and this study has clearly shown the increased risk for arterial thrombosis in patients with COVID versus those without. Another study again looked at acute arterial and deep vein thrombosis now, and again this was in the first 2 months since COVID-19. All patients had COVID-19, and they looked at lower limb thrombosis or DVT. The mean age was 68 years. 1 patient died in the lower limb thrombosis group, and 3 patients had amputations, whereas patients with DVT, 28% of patients died of major organ failure. And I doubt that this is because of DVT itself. I think it's partly because of the cytokine storm and the COVID situation. But patients who died had raised fibrinogen, CRP, and D-dimers, as we showed earlier. Again, some of the risk factors that are seen quite prominently in patients with diabetic foot problems. So what will happen if the pandemic does continue? And this is an excellent study done by Ghoshal Mishra and colleagues, where they used a simulation model from previous pandemics, and they looked at using a multivariate regression analysis, what will happen to some of the important risk factors in people with diabetes if lockdown were to continue. And they showed that if the lockdown were to continue for 30 to 45 days, you would see a 2 to 3% increase in HbA1c, a 10 to 20% increase in neuropathy, a 3 to 4% increase in amputations, but also an increase in myocardial infarction, cardiovascular, strokes, and also infections. So all of these risk factors, which are important that we deal on a day-to-day basis, if patients, if the lockdown were to continue for a significant amount of time, we could see deterioration of all these risk factors and clinical parameters in our patients. So how do we manage adaptic foot ulcers in the COVID situation? There are a lot of algorithms that have been published, including the International Working Group on the Diabetic Foot, NICE, etc. This is a lovely algorithm from India by Atri and colleagues. And here they recommend home community care and teleconsultation in most situations, unless the patients have got osteomyelitis, Charcot foot, where they might need hospitalization and then ongoing care in the community. Another study from India, again, similarly describing that if patients have got mild symptoms, then managing patients by online consultation. If that is not possible, then patients can be seen in the hospital where appropriate management can be given with follow-up via telemedicine. This is FD UK, which has again described the protocol for managing and preventing a lower limb amputation, but this has not changed from the pre-COVID situation, and they again stress the importance of regular assessment of the foot and appropriate management of people with foot ulcers and also ischemia. What is our management protocol in our hospital? Patient presenting with adaptive foot ulcer, we initially assess them in the clinic, so face-to-face using appropriate PPE. We do a COVID test if required, but all patients who come into hospital will have a rapid COVID test. We get the results within 2 to 4 hours. We do a complete foot assessment, what we call triage. So we look for neuropathy, PAD, and any infection. Arrange investigations as necessary. So blood tests, full blood count, CRP, HbA1c, etc. Do an X-ray if required. If the ulcer is deep, probing to bone, we then dress the wound, provide offloading footwear, discuss glycemic management. And we're using a lot of insulin these days because we know that patients with diabetes have got increased risk for mortality. So we are trying to bring the blood sugars down as quickly as possible. We also do cardiovascular risk factor management, blood pressure, lipids, antiplatelets. We're using a lot of DOACs now, one because of the procoagulant state of diabetes, but also the procoagulant state of the coronavirus. And with the COMPASS study, which has had a nice presentation yesterday at this conference, we are using a lot of DOACs to prevent people from developing ischemic legs. Subsequent follow-up depends. It could be face-to-face or teleconsult. We are privileged in the UK that we've got district nurses, so the nurses can visit patients at home. They can send us pictures. We can do video consultation. It's difficult for the patient to do this because most of these patients are elderly. They don't have the know-how, the technique, or the availability of teleconsultation. So if we were to do to the patient, it would be by telephone. But we are using district nurses. Our podiatrists also will visit patients at home, and then we can do teleconsultation with them. If antibiotics are necessary, we prefer to use oral antibiotics. If IV is required, we have now set up an IV at home therapy where the nurse will go to the patient's home. They'll put in a midline, a PICC line, or Venflon, and patients are given IV antibiotics at home. And we tend to use stuff, flucloxacillin or ticagrelor as part of the treatment regime. And this way we can avoid admission to the hospital. So NHS England has come up with its own guidance. This is for general practice, and they do recommend, where possible, to do a one-stop visit that prevents patients coming in to contact with healthcare professionals, but also others where social distancing may not be done properly. So at one-stop visit, get the blood test, foot examination, and check urine for microalbuminuria. And this is what's happening at the moment here in the UK. So coming back now to the vitamin D story, this study, which was done by Rastogi and colleagues in PGI Chandigarh, looked at vitamin D supplementation in patients with COVID-19. It was a randomized controlled trial. All patients had low vitamin D levels, and patients who had COVID-19, they had mild or asymptomatic disease and no comorbidities. 16 patients received very high dose vitamin D for 7 days on a daily basis, repeated for another 7 days if the vitamin D was less than 50 at 7 days. Total dose given was 14 days. and that the controls did not receive vitamin D. All patients had oropharyngeal swabs at intervals up to 21 days. They also measured the inflammatory markers, PCT, fibrinogen, and D dimers. And what they showed, vitamin D levels improved in the intervention group as you would expect, but there was a reduction in fibrinogen, and you can see the vitamin D levels there. But what was more important is that patients who had high dose vitamin D, there were more chances of becoming COVID-2 virus negative, so 62% versus 20% at day 21. You can see the p-value there is significant. What about treatment for COVID-19 with vitamin D? This study here done in Italy, they used calcifidiol treatments, that is 25-hydroxy-D. They randomized patients who received or did not receive calcifidiol. It was an open label study, and they looked at ICU admissions. Patients who did not receive the vitamin D, you can see that 50% of patients required ICU admission compared to only 2% for patients who received the vitamin D treatment. So there is some evidence coming out there that vitamin D may be beneficial for people with COVID-19. And this is a study that we did here in Tameside Hospital. It was a 3-center study, Tameside with Preston and Leicester. And we looked at high-dose cholecalciferol booster therapy, and we showed there was a reduced risk for mortality in patients with COVID-19. And we showed that patients who had low vitamin D levels, also those who had borderline normal vitamin D levels, actually improved when they received booster therapy. This was an observational retrospective study done in about 1,000 patients here in the UK. For lack of time, I'm not showing the slides, but the study is available online. If you want to read it, it's free to download. What we also showed in this study is that patients with blood sugars of more than 6.9 on admission had higher mortality. So all the more reason why patients coming into hospital should have their blood sugars measured, and if possible, given vitamin D. So in conclusion, there's a similarities between the presentation COVID-19 and diabetic foot complications, namely diabetic foot ulcers, and maybe an interrelationship is highly plausible. Due to disruption in healthcare and the apprehensiveness of patients to visit hospital, greater need to telehealthcare should be encouraged. Improved treatment at home or the community, such as podiatry, IV antibiotics at home, will help maintain care for patients with foot ulcers, reduce risk for amputation, and possibly reduce hospitalization. Self-examination by patients to identify early ulceration is crucial, and we recommend this to all patients now here in the UK to examine their feet on a regular basis. And we advise them if they find any change in the foot, discoloration, pain, swelling, or breakdown in skin, they must inform the multidisciplinary foot care team. Vitamin D deficiency plays a role in both disease conditions. I've shown you data both for diabetes and also for COVID, and healthcare professionals must strive to manage this appropriately because there is an interplay between vitamin D deficiency, COVID, and diabetes, and also diabetic foot complications. So governments and healthcare providers must play an important role in the delivery of care for diabetic patients, especially for diabetic foot patients. So thank you very much for listening.